Patient RM is a 40-year-old male with history of hyperlipidemia who comes into the clinic today with complaints of intermittent chest pain over the last 2 weeks. Today's visit he booked a few days ago, and it was not a routine follow-up. Patient appears to be in no distress walking into the exam room. He has a history of hyperlipidemia, which has been managed by diet and lifestyle changes. He is not currently medicated for this, and his lipid levels remain at target levels. Prior to these chest pain episodes, he's been a quite healthy individual with no other health concerns other than his hyperlipidemia, which has been managed. The onset of chest pain began 2 weeks ago in the evening, 20 minutes after eating supper. He reports the pain as a 5 out of 10 that is retrosternal and radiates to the mid to lower back. Aggravating factors include bending over, laying down, and eating large meals. He reports alleviating factors as rest and in between eating large meals. He reports his pain as mild to severe intensity and associated symptoms of regurgitation. He has tried Tums and reports that he felt some relief with this of one of the chest pain episodes. Patient has not experienced chest pain prior to the episodes he's had in the last 2 weeks. And the last chest pain episode he experienced was last evening, an hour after his last meal. Predisposing conditions and risk factors include his hyperlipidemia and alcoholic intake of 8 alcoholic drinks per week. Pertinent negatives include no family history of hyperlipidemia, he's no shortness of breath, no palpitations or any cough, and he's also a non-smoker. He went to the ER last week with one of the episodes of chest pain, and a cardiac workup was done. The ECG was negative and cardiac enzymes were also negative, so troponin was negative. RM is not on any prescription medications. He has no known allergies. His family medical history includes that his father also has hyperlipidemia, which he is medicated on Lipitor for. Mother, no significant medical history, and no other significant family medical history. His patient's social history, he's married with 2 adult children, lives in a stable living environment with a good support system. He does report an increased amount of stress lately due to a job change in his role as a social worker, and he denies any substance use. Upon a physical exam, the patient appears to be in no acute distress. He weighs today at 82 kilos and height of 5 feet 9 inches. BP on the right arm sitting is 130 on 80 and left arm 134 on 84. Temp 36.7, pulse 85, regular, resps 18, and O2 saturation is 98% under Mer. Upon assessment of the extremities, the upper extremities are warm, temperature bilaterally, pink in color with no abnormal masses or deformities. Pulses, radial and brachial are 2+, nice and brisk, and cap refills less than 3 seconds. Lower extremities reveal that the skin is nice and warm bilaterally and pink. No abnormal masses. The pulses, the popliteal, posterior tibialis, and the pedal pulses are all 2+, nice and brisk, with capillary refill of less than 3 seconds. Carotid upstroke is brisk, and the JVP is 2 centimeters at the sternal angle with the head of the bed 30 degrees, and no carotid bruits. Normal heart sounds are heard S1 and S2, no murmurs or extra heart sounds of S3 and S4. It's a regular rate and rhythm. No thrills or heaves palpated on the chest. There's chest wall tenderness reported on the left side of the chest in the mid-axillary area. The PMI is tapping with a size of 2 centimeters, and it is palpated at the 5th intercostal space mid-clavicular line. Chest is clear bilaterally, symmetric chest expansion, no adventitious sounds are heard, and no labored breathing, and percussion reveals resonance. Abdomen is soft, bowel sounds are present, no bruise, no pain or tenderness with palpation. In summary, this patient, male RM, is a 40-year-old male patient with history of hyperlipidemia who presents with complaints of chest pain over the last 2 weeks prior to today's clinic visit. Patient has no apparent distress, no history or family history of cardiovascular disease other than his father has hyperlipidemia. The episodes of chest pain have been related to after eating large meals. Patient has tried Tums and found that it was effective at relieving an episode of chest pain. He had a recent visit to the ER, which revealed a negative ECG and negative tropes for these complaints of chest pain. He has had a recent job change and reports increased level of stress on a regular basis currently with this change. Vital signs are stable today in clinic. BP 130 on 80, right arm, 134 on 84, left arm sitting, temp 36.7, pulse 85, regular, nice and brisk. Resps are 18, and O2 saturation 98% on room air. Skin is warm, all pulses are present, brisk, 2+, colors nice and pink, and no edema. Chest is clear bilaterally, no shortness of breath. Cardiac exam reveals a normal S1, S2, no murmurs, no extra heart sounds of S3 and S4. JVP is 2 centimeters at the sternal angle with the head of the bed at 30 degrees. There is some chest wall tenderness reported on palpation of the left chest mid-axillary area, and his last complaints of chest pain were last evening after his last meal. Currently, patient is in no chest pain at this clinic visit. Assessment of this patient from going over the subjective data and all the objective findings from the physical exam would reveal chest pain not yet diagnosed, and some differential diagnoses include GERD, angina, chest wall pain, costochondritis, and also anxiety. The plan, treatment, and diagnostics interventions are not included for this assignment. Thank you for listening.